Hey guys, what's up? It's Stephanie. Welcome back to my channel. So in the video today, I'm going to be making a video in regards to my third month and a physician assistant residency / fellowship in critical care medicine. Hopefully this video is helpful for you, for those of you who are wanting to pursue a residency / fellowship in critical care medicine, or even in emergency medicine, or just any fellowship or residency in general. I hope this video is helpful. So just real quick, a little bit about me and the residency that I'm currently doing. So I graduated in the fall of 2020, so this was last year. I wanted to pursue critical care medicine. I had done a rotation, an inpatient rotation, and I felt like I wanted to learn more. Specifically, since in PA school, we really don't learn a lot about critical care medicine in regards to like ventilators, how to troubleshoot them, what are arterial lines, how to place arterial lines, how to place central lines, etc. And so that's why I decided to do a residency in critical care medicine. And so when I found out there were several critical care medicine residency / fellowships, I decided to apply to them. Thankfully, I was accepted to the one I'm currently in right now. So the residency / fellowship I'm in is for advanced practice providers, which includes both nurse practitioners and physician assistants. They only accept 2 APPs, whether it's a physician assistant or nurse practitioner, and you do a 1-year residency or fellowship. You do 13 rotations throughout the residency, and each rotation is purely critical care medicine, but it's in a different specialty of critical care medicine. So the ones I'll be doing, for example, are surgical trauma, neurovascular ICU, surgical trauma ICU, surgical ICU, neurotrauma ICU, transplant ICU, cardiothoracic ICU, rapid response team, and you also have some elective towards the end of the year, and you can choose wherever you want to rotate, depending, of course, into what specialty of critical care medicine you want to go into. So for example, if I want to do surgical trauma, then I would be spending a rotation at the surgical trauma bay or even in the OR, so I can familiarize myself with surgical trauma patients. Also, another thing I like about this rotation is that in critical care medicine, you, of course, and I think just in general, the majority of the specialties that you go into, we read a lot of imaging, whether it's x-rays, whether it's MRIs, whether it's CT scans. But in critical care medicine, you do a lot more of that. So you read them a lot every day, daily. And I really like about the rotations that you're able to do a month in radiology, where you will get more in-depth training in regards to reading MRI, CT scans, x-rays, etc. So that's what I really liked about this residency. So what rotations have I completed so far? So my first month was in surgical trauma ICU. My second month was in the neurotrauma ICU. And my third month, which I just completed, was in the neurovascular intensive care unit. So you're probably asking yourself, what's the difference between neurotrauma and neurovascular ICU? So neurotrauma, we saw a lot of more traumatic injuries in regards to the neurological system. So that included a lot more spinal injuries, a lot more head traumas. So whether it was spinal injuries that were obtained from a motor vehicle accident, an individual diving into a pool that was not deep enough and they ended up injuring their spinal cord. I had a patient that was trying to do a handstand on a motorcycle, ended up falling on his head and becoming, unfortunately, a paraplegic. And those were kind of the type of injuries that we saw in the neurotrauma. So any type of traumatic injury to the brain, to the head, whether it was self-inflicted. So for example, brain injuries were gunshot wounds, patients that were on bikes that do not wear their helmets, and they ended up crashing, hitting themselves against the wall, and they ended up having a traumatic injury to their brain. So I saw a lot of traumatic brain injuries there, and any type of injury to the spinal cord. Other examples, for example, would be metastasis from cancers that go to the spinal cord or to the brain, were other type of patients that we saw. Versus neurovascular ICU was a lot of patients that we saw were stroke patients, subarachnoid hemorrhages, also epidural hematomas, subdural hematomas. The majority of our patients were stroke. And the thing about this is that I did this rotation during COVID-19, and we were very, very busy. So that rotation, I loved that rotation. It was a lot of work. I worked 6 days a week with 1 day off, and then included sometimes also 24-hour shift. If I did have a 24-hour shift, then I would work about 5 days, and then I would be post-call on my 5th day. So on my 6th day, so technically I would have 1 day off. because that post-call day I would sleep all day. So yes, 24 hours, 6 a.m. to 6 a.m. the next day. And sometimes you're able to sneak in a nap, and I'll be honest with you, the days that I was on the 24-hour call, I did not sneak in a nap because we were so busy. And the reason why is because of COVID-19. So for those of you who are not familiar with COVID-19, it tends to make the blood more coagulable. We saw a lot of cases where it was causing a lot of pulmonary embolisms in patients. And now what we're seeing specifically is that it's causing a lot of strokes in your younger patients, which is very, very scary. It scared me a lot. Specifically, I would have patients that were 24, 26, 27, 28, 29 that had these big strokes because of COVID-19. And I'll be honest, the majority of them were unvaccinated. I think I only had one patient that did have a stroke and he was vaccinated. I had another patient, she had a stroke. She only received the first dose of the vaccine, so she didn't complete the entire vaccine regimen and she had these strokes. And these were bastard strokes, so they were very, very bad strokes. So for this rotation, I really enjoyed it. Like I said, very busy because we just had a lot of patients that were having strokes that were young from not being vaccinated from COVID-19. In addition to that, the thing about this is that most of these patients that are COVID-19 and just in general, they don't stay in the ICU for a few days. Usually in the ICU, it's a rapid turnover, right? A few days and then they get transferred to the floor. COVID-19 patients usually would stay with us for weeks. I had one patient that was there with me from day 1 until day 30 of my rotation, and I was taking care of him every day. He was a COVID-19 patient who had a bastard stroke and then started developing acute respiratory distress syndrome, ended up having to have a tracheostomy. We finally were able to place him off precautions, and then he still started getting all these pneumonias. So I became very familiar with this patient throughout the 30 days because I was just seeing him daily. I was taking care of him daily, and I would see how he would progress, and then he would subsequently get worse, and etc. So those were some of the patients that I saw. I also saw very weird cases. I had one patient with West Nile virus, which was very interesting. So sometimes you would get crazy things like that. I would get patients with meningitis, vestibular schwannomas. So vestibular schwannoma was something that was never mentioned in PA school for me. And if it was very, very quickly, and I didn't learn too much about it. But during this rotation, I saw so many cases of vestibular schwannomas, and I got very, very familiar with vestibular schwannomas. Same with meningiomas, brain tumors, etc. So these were kind of the patients that we saw. I got very familiar with reading MRIs and CAT scans. In comparison to neurotrauma and neurovascular ICU, is that in neurotrauma, if you haven't seen my previous video, it was usually just 3 of us for the entire critical care medicine unit, but it was only 10 beds, which is not bad. This rotation, it was 20 beds, and it was a lot more of us. So it was sometimes it would be 8 of us, 10 of us. Also, if we had some medical students, it would be a little bit more. And we had residents that were in ears, nose, and throat residents. I had pulmonology fellows, critical care medicine fellows, of course. I would also have neurology residents with me. So we had like a little bit of everything. And I really enjoyed this rotation because we all worked together. And of course, like ENT residents knew a lot more in regards to like vestibular schwannomas and just ENT things. And we would be learning from neurology residents versus like the neurology residents, they would tell me, I don't know medicine, I just know neurology. And so sometimes I would teach them about like cardiovascular medications, pulmonary medications, etc. And then we had a pulmonologist fellow who was amazing with the ventilators and anything pulmonary wise, but she decided to do this, for example, month in critical care medicine neurovascular because she said that neurology is one of her weaknesses, and so she was learning a lot alongside with us. So we were all coming from different backgrounds, but we were learning so much. And I really like this rotation because rounds were very long. We would start at 8:30. Sometimes we didn't finish till 3 or 4, especially if we were running on all the patients, and there would be patients that would get really sick, like especially our COVID patients. They tend to decline, and when they do decline very rapidly. And so when they did decline, we had to pause our rounds, go, and then ensure that the patient was fine. Remember, the last patient I had was a COVID-19 patient also, came in for a stroke once again due to COVID-19. And I remember putting an arterial line in the room with him. And right when I was putting the arterial line, he started descending in regards to his oxygen level. So I ran down, I went to go get my attending because they were still rounding, went upstairs. We ended up getting the surgery team because they ended up having to place bilateral chest tubes in the patient while he's in the room. And so we were all gowned up. They placed bilateral chest tubes. And then of course I'm there trying to put the arterial line, and then someone else is trying to put the femoral line. So we were all working together. It was like 5 of us in the room, like with the chest tubes and then the arterial lines and the femoral lines. So I really like that about this rotation. Now, in regards to procedure-wise, how do I feel? I feel a lot more comfortable with arterial lines. I remember the first rotation that I started in surgical trauma, I didn't do any procedures whatsoever. I just observed. And then second rotation, I was able to do some bronchoscopies, which I got a little more comfortable with. And then my third rotation, now I did an arterial line almost every day. So there were several times where I failed all the time. And the interesting thing is that the fellows that you're with really like to teach. And so you will learn differently on how to place an arterial line with a pulmonary fellow in comparison to a surgery fellow. So the surgery fellow that I was with, he's so good with his hands, like placing tubes, placing central lines. And he was the one who was teaching me how to put arterial lines and femoral lines, and he's just so good with his hands, And then a pulmonary failure is just, she's very like particular, very like specific, and you just learn very different ways. And of course you tend to adapt and see what way works better for you. And so I got to do arterial lines almost every day during this rotation. I did some femoral lines also. I learned how to place also blind femoral lines especially. So most of the arterial lines, we tend to do ultrasound, and we'll use an ultrasound so that way we can differentiate between the artery and the vein, ensuring we're putting the line in the correct artery for arterial lines. Same with our, for example, central lines, whether it's in the IJ or whether it's in the femoral. You want to make sure you're putting it in the vein and not in the carotid in regards to the neck, and then in regards to the femoral, ensure that you're putting in the femoral artery, not the vein, or vein, not the artery, etc. And so we usually use ultrasound, and sometimes during crash times where the patient is crashing, like this COVID-19 patient, sometimes someone else is using the ultrasound, or you don't have time to go and get the ultrasound and make sure it's sterile, etc. Especially with these COVID-19 patients, you have to make sure that you're acting quickly and doing it blindly. And so I was taught on how to place a femoral line blindly, just palpating where the femoral arteries and just boom, going in and doing it less than 5 minutes, less than 3 minutes, just in, out, super quick. And so that's something I really liked about this rotation. And I think it was just because we were so busy and we had such sick patients. And the thing about these patients is, especially the COVID-19 patients that tend to stroke, is that they keep stroking. So, and that's something that's very sad about COVID-19, is that once you stroke, you keep stroking over and over again because it just makes your blood very hypercoagulable. And so that would be the case that I would see on these patients. And that's why we would also do, more like the nurses would do, neurological exams very, very often throughout the day, whether it was Q2 hours, Q1 hours, Q4 hours. And if they noticed any change in the exam, they would notify us. And they will also notify the neurological team or the neurosurgery team. And of course, they would come and they would do their exam, or they would send them straight to get a repeat CT scan and ensure that there wasn't, for example, a new brain bleed or increased intracranial pressure, etc. I got really familiar with the EVDs. I got really good with reading my brain MRIs, head CT scans. I got really good with my neuro exams in general, because you're doing neuro exams daily and on every patient that you would see. And sometimes on the weekends, we had very, very short, not enough personnel. So sometimes it would be 3 of us for 20 beds. And those weekends sometimes would be really crazy. It was like a hit or miss. And I think those were the times where I learned a lot, because from 6 a.m. to like 4 p.m., sometimes I wouldn't get a break to eat, just like snacking in between. It's like go, 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 go. And the attendings really like to teach during rounds. And so I learned so much in regards to pathophysiology, pharmacology, like what's the pathophysiology of vasospasms, right? Cerebral vasospasms, and why we watch out for them. Why do these patients have caps of blood pressures? Why do they have a MAP floor, etc.? Why are we using this medication over this medication? Why are we trying to take the patient off a drip to control their blood pressure and transfer to medications that are not drips? Why are we doing this medication versus this medication? And this was something that we discussed a lot during rounds. And so that was something I really liked about this rotation. So this is my third month. I feel like I've learned a lot more in comparison to where I was in the first month. So now I feel a little bit more comfortable with bronchoscopies, placing arterial lines, a little bit with femoral lines. I think I need a lot more practice. I was able to place a internal jugular line on a patient, but I do have to say that I was very nervous. I only placed one, so I'm not very comfortable with the neck, but I think I'll probably get more procedures with this next month that I'm going to. So I'll be going to the surgical ICU next month. But I got very comfortable with reading scans, CT scans, and MRIs. I got a better understanding in regards to strokes, how to manage them, what do we look for, why neurological exam are so important. And then I also got to see how terrible this COVID-19 disease is and what it does to the brain and just the body. And so I really enjoyed this rotation. I'm really excited to see what my next rotation does. And I'm very happy that I did a residency or fellowship, because I will say that I was exhausted. There was a day where I worked 9 days straight, and multiple days I did not get to eat because we were so busy. I wouldn't get lunch breaks. Sometimes I would get home and wouldn't start eating until 7 p.m. And the last time I ate was like at 4 a.m. But it was definitely a good learning experience. And now that I'm in the surgical ICU, which I'm in right now, surgical ICU is very different. It's very calm. I miss that rapid, like, okay, this patient's crashing, go in there, put the lines, make sure you make these phone calls and let neurosurgery know, let neurology know. I miss that I just miss it. So, well, I hope this video was helpful for you guys. For those of you who are wanting to do a residency or fellowship, I highly recommend it. As you can tell, I've learned a lot from day one to where I'm at now. I feel more comfortable with procedures, reading certain types of imaging, and also with certain types of patients, in this case, neurovascular patients, neurotrauma patients, and then surgical trauma. And you think I need a little bit more, but these 2 past months I've been in neurology, anything with neuro, so I feel very comfortable with neuro at this time. Of course, I don't know everything, but I feel comfortable in comparison to where I was where I started. I was deathly afraid of starting neurotrauma and neurovascular ICU because these are my weaknesses, and thankfully these rotations help me really kind of love my weakness. And hopefully I hope to pursue this after the residency or the fellowship is completed, but we will see. I still have multiple rotations to go through. All right, guys, I hope you guys like this video. As always, please leave any comments if you have any questions. If not, then feel free to send me a message on Instagram. I apologize if I take a while to respond. As you can tell, my rotations have been really busy, and it seems like the previous days, all I do is just go to work, get home, sleep, shower, do the thing the next day. Same thing every day. And then usually on my days off, I sleep all day. So I apologize if I take a while to respond, but I will respond. All right, take care, and I'll talk to you guys later. Bye.